Let me just begin by introducing myself. My name is Iyad. I'm the program coordinator for ORP Maldives, and I'll be moderating today's session. Before we begin, I'd like to take a moment to thank all the veterinary doctors, nurses, and students for joining us today. Your work is crucial not only for the welfare of the animals, of course, but also for advancing the knowledge in this field. We truly appreciate all of the work that you do, and we thank you from the bottom of our hearts for bringing us up until to this day. All of the successes we have, we owe much of it to you. And in the same spirit, I'd like to briefly highlight a fund match campaign that we have currently running. It's very exciting because it allows everyone to support the life-saving care for our veterinary team that our veterinary team provides for to injured sea turtles. We're aiming to raise about £40,000, and we've already reached about around 60% of our goal. So we're very well on our way, but we still need all of your support to help us get there. So if you could just share the information around, or if you'd like to participate in yourself, please feel free to do so. Uh, any contribution you make to this automatically will be doubled with no extra cost to you. But this will only last until the 29th of April, midday time of UK time. I'd also like to briefly introduce ORP as an organization. Just for those who may not be familiar with our work, ORP was founded in 2013 with a mission to protect sea turtles and their habitats through rescue, conservation medicine, and scientific research, as well as educational outreach. We are headquartered in UK, and we run programs here in Maldives, in Kenya, Seychelles, Oman, and Pakistan. So pretty much covering majority of the Indian Ocean region. The insights shared in today's talk uh, draw from our sea turtle rescue and conservation medicine efforts in Maldives specifically, which are led by Dr. Max Polyak. He's the ORP's Director of Conservation Medicine and our guest speaker for today. I'll just hand it over to you, Dr. Max.
Thank you, Iyad, and thank you everyone for joining us today. I hope you're having a wonderful day wherever you are this weekend. I'm coming to you, as Iyad mentioned, from my home in Saudi Arabia, and I'm excited to share a little bit about what we're doing within conservation medicine and sea turtle medicine and health overall. At the Olive Ridley Project in the Maldives. Okay, so I'll get started by sharing my screen. And okay, can you all see this? Okay.
Yes, Dr.
So,
Max, I think we can see it.
okay, great. Thanks, Iyad. So what I want to discuss with you just for a moment, because this is a really broad and fairly deep topic, is a new approach to treating and hopefully saving sea turtle limbs. And it's a holistic approach to the management of these types of trauma, but using conventional methods, which I'm not going to stress that much, but using molecular and integrative approaches to not just complement conventional techniques, but to actually supplant them. And hang on. No, it's not. There we go. Okay. So to supplant them. So let's get started here with a little bit of what we do on the conservation medicine side at the ORP. Now, we function, and I always say this, and some of you may have heard this before if you've heard me give a talk like this, is we model ourselves like in a sea turtle university model. So what does that mean? I mean, if you speak to anyone, more or less, they have an idea of what a university does. And if you apply it in a sea turtle context, a university has a teaching hospital for like its veterinary or medical schools. It obviously does research within that context, and it teaches and it trains the next generation. So that's exactly the paradigm we have used and applied it to conservation medicine and specifically sea turtle medicine. And all of it is rooted in a One Health approach. So, a One Health approach, just very briefly, for those of you that may not be familiar with it, is the link between animal, human, and ecosystem health. And that sometimes may sound intuitive, but it's not always obvious to people how those links are made. And so I just want to speak very quickly about that because I think it's important, not just for this lecture, but kind of looking at conservation medicine as a forefront specialty within veterinary medicine, because it very much is. Um, so if I treat or we treat the individual animal, that's wonderful and gratifying. And it's what we're going to be talking about today. Um, but how does that impact the health of you or me? Well, within the context of treating this animal, we have the opportunity to learn a lot of things about its health, its underlying health, um, what has caused it to be admitted, but probably more importantly, what's going on with it, independent of the presenting condition. And those clues give us insight, those health clues give us insight into the health of that animal's local ecosystem. So whether it's a local reef or a larger kind of seagrass meadow or something, an ocean or a sea or an entire atoll or country like in the Maldives, they're kind of moving surveillance tools that we can utilize to determine the health of the ocean. And by definition, if we understand better the health of the ocean, the planetary health, we understand better as well. And we are all part of that in a very intricate way and on many, many levels. So with that background, let's get into kind of what we do here in the Maldives. We utilize this university model, Sea Turtle University model, to innovate, constantly innovate, to conduct clinical research and health research. So those are two different things, and we do both of them. One is more geared towards the animal itself. Health is more geared towards the animal within the context of its ecosystem in a One Health paradigm. And then we obviously do a lot of time training. It's really important to us and to me personally, everywhere I am, whether it's in Saudi Arabia or in Maldives, I like to teach and train, and all of us do. We have a really large clinical team. We have 6 veterinarians, including myself. 5 are on the ground in the Maldives. We have a very diverse background in terms of geography, where we came from, culturally, where we came from. I'm Californian, but I'm living in Saudi now. We have Indonesia, we have Kenya, we have a new vet coming from Brazil, we have the UK, a new vet who just left us today. Not a new vet, a vet who just left us today, actually, his last day, Dr. Pau from Spain, but a vet that's replacing him from Mexico. And then we have our intern on them, who's a wonderful asset. So it's a great team to work with, and I'm very proud of them all. So what has been kind of what have we been up to in the Maldives? What has been our impact? What has been our outputs, actually? And so since the very beginning of it, when it was just one center, this Marine Turtle Rescue Center, which is down here on the picture on the left in Ba Atoll, which is kind of in the center of the country. We've admitted over 275 patients, which for us and for the country is a lot. It may not be a lot for your local context, but it's certainly a lot for where we are. So it makes a big impact. We have the largest sea turtle specific clinical team in the world with 6 vets. 6 sea turtle vets is a real luxury, and we're really grateful and blessed to be able to grow as a charity collectively. And it's not just the conservation medicine team that has grown, but all of our kind of departments and different aspects of our mission have grown equally robustly. So we're really blessed to have that. We have the three facilities. The Marine Turtle Rescue Center is kind of like our original sea turtle hospital. It's a full functioning teaching hospital, and it's been around since 2017. We have a relatively new sea turtle care center at Ra Atoll, which is still kind of in the center of the country. This is more of a step down unit. It's a smaller facility that allows us kind of the ability to put patients for long-term therapeutic care and observation in advance of their hopeful release. And then our brand new Sea Turtle Health Institute, which is a state-of-the-art true sea turtle hospital by design, just opening up. Actually, our grand opening is going to be next month, but it's been functionally opened. Full. We have a full house already for about 3 or 4 months now, and that's our main hospital tank there in the picture on the right. So that's what we have facility-wise, and in terms of releases, we have released about over 150 now sea turtles back into the wild. So, if you read the news sometimes and you hear things about like just awful events where you see huge bycatch stories and things like that, where there are thousands of animals sometimes that are entangled, you wonder like what good is 150? But 150 or even one for that matter is very important. It's very important if you maximize the time you have with them as patients to learn about not just their health, but also the other things I discussed already, which is the context of that health within the ecosystem health and within the larger oceanic health. Okay, so that's why it's important. Now, what is the problem? What are we talking about today? Well, in a nutshell, you're looking at the problem. So this is a ghost net, an amalgam of marine debris that is collected and that captures and entangles marine fauna, and in particular marine megafauna. And sea turtles are marine megafauna. Other animals get caught in here too. Now, for perspective, this is a mild entanglement. We get way, way worse than this, but this gives you an idea that the animal cannot leave. This one can likely surface to breathe, but very often they cannot, and they drown. And the types of injuries and trauma associated with this type of event, this entanglement, is enormous. And so, of the major things that we see in the Maldives, the presenting conditions for the veterinary surgeon really fall into two categories, which is about 95% of our presenting conditions. The first is buoyancy syndrome, so floating sea turtles, which we're not going to talk about today specifically. And the second is entanglement trauma, but they often come together. They show up together. So really, you're either treating one as the primary presenting condition, and then secondarily, you have, let's say floating, or vice versa. So they really kind of all go together. So this here, in a nutshell, is the problem. And we have entanglements all over the world, but not in the way and the frequency and the patterns that we have in the Maldives. So it's something that is it's a niche presentation within a niche group of animals, not just sea turtles, but the fact that they're olive ridleys, which is not a common animal to see in a hospitalized environment. And then this allows us to do a very, very deep dive into these two presenting conditions. So we can learn maximally about each patient, and we can apply maximally the therapies that are kind of the cutting edge, the things that we've been able to innovate and develop, and others as well to apply to our patient population. So what is the standard of care right now? What is the gold standard for something like this? Well, if you, as a clinician, decided to amputate this limb, it would be a sound clinical decision 100% of the time. Absolutely. This is a very bad wound. This trauma is, you could see exposed, not just exposed bone, but you can see this is dead bone. So this joint is open when, as you know, as veterinarians on here know, if anything that's inside a joint, the joint doesn't like it. Probably of any structure, the joint is least happy about things inside it. So if the joint space is breached in any way, even in a small way, it's a bad thing. If it doesn't exist anymore, which is what you see in front of your eyes, it's a very, very bad thing. This tissue is not vital anymore. It's and this limb is just falling apart. So I bring this picture up here and describe it to you. I'm going to describe it to you for a reason. This patient is the very first patient that started our thought process on the innovation of this limb management protocol. Because I was trained, and I was trained very luckily by perhaps the very best sea turtle clinician in the world who wrote the textbook, and we would just chop this thing off, so to speak. But we thought about it and we said, there's got to be a better way. And I always encourage our students and young vets that I train, like we have to think as scientific entrepreneurs. As a clinician, you should really try and think as an entrepreneur. It's not a mindset that's only for business or something. It's a mindset for anything in your life. And if you think as an entrepreneur, you think creatively, like you create as you go. And as a surgeon, we're taught to not really create. We're taught to identify a problem, and we're taught to fix it. And you better know how to fix it. That doesn't give you a lot of room for creativity or thinking outside of the box. So I still, despite that, I encourage you to do it. And that's what we did with this little guy. So this is a juvenile grain that actually is a patient of mine when I was in South Florida practicing sea turtle medicine. And we asked ourselves, what about a different path here? Let's try to save this. So we put our heads together and we went down that road. And this lecture really reflects that entrepreneurial thinking from a clinical point of view. I'm going to weave pictures of him throughout this lecture, and then I'll show you what it looked like at the end. Okay? So that's the background of this little guy. Now, what is the protocol? All right, so a lot of this, there's a lot of words on here, but I'm going to, in a nutshell, describe kind of each section. So it's multimodal, and it starts like anything starts in our practice with a good examination. Every patient, whether it's an entangled patient or not, gets a full comprehensive clinical exam. So that is a physical exam, that is a cardiopulmonary exam, and very importantly, it's a neurological exam, especially for these patients. We do full blood work, imaging studies, and other diagnostic tests, in addition to obvious things like morphometrics. So this happens for all of our patients, and regardless of the environment you're practicing medicine in, you can accomplish the first three easily. You don't need fancy tools for it. And in fact, for blood work, you don't really need very fancy things either. Some of the imaging you might, but the basics of practicing medicine as a veterinarian, and kind of what we're celebrating today on World Veterinary Day, is getting back to the basics of what you learned in school and doing it repeatedly and doing it the right way. Now, the neurological exam, I really stress, especially in these patients, because what we're trying to do in determining whether or not we're going to go down the path of attempting to save the limb, or we're going to amputate it, because we still have to do that on occasion, is we look at two things. Is there a response from a nociceptive point of view? Does it feel you manipulating it? Does it still feel pain, in a nutshell? And also, is it able to ambulate that limb? Is it able to exhibit proprioception? Does it know where that limb is in space? Those are two different nerve tracks into the brain, as you guys know, and one can be damaged and the other function, or vice versa, or both damaged. So these are things that we test in a neurological exam in a comprehensive way to determine the feasibility of going down the salvaging path. All right. We usually, these animals are in really bad shape. You can imagine they've been anorectic for sometimes many months. So they're debilitated. And so the trauma to the limb, in a way, is a secondary feature to stabilizing them as a patient. So we obviously do that first, and we make sure that everything is done in a very deliberate in ritualistic, clinically ritualistic fashion. It's the same thing every time. So everyone who comes into our hospitals as a new clinician will learn the same thing, and they will leave the last day doing the exact same thing for a new patient. Okay. And that's where that consistency is built in to make sure that the overall care of your patient is done appropriately. Um, so we stabilize the patient. We make sure that, and we don't get into fixing that limb right away. In fact, we wait sometimes days, sometimes a couple of weeks even, to do anything to that limb. Because usually when they come in, it's very rarely a fresh wound for us. It might be, but it's very rarely. So there's some days, weeks, even months where there's been some healing or some response in the tissue to what's been going on. So that's a very important point that I want to offer to you as colleagues is don't rush into things with sea turtles in general, and especially with the limb work. Give it time and assess what is going on, okay? Because your eyes will deceive you. Always default back to your examination results and the results of the overall diagnostic workup, okay? Many times I've been made a fool of thinking I see something, I know exactly what's going on, and I'm going to just deal with it. And it turns out I was completely wrong. So I very much stress slow down. There's nothing you can't do tomorrow, 3 days, 5 days that you can't do 5 days from now that will do anything to improve the chances of saving that limb. So then we move to the integrative intervention. Once we have the patient stabilized, once let's say the debilitation has a treatment plan in place, we can start to look at what we're going to do with the limb. And very often we will start with conventional methods of some debridement. We need to remove dead tissue, just like this picture on the bottom. The picture on the top is an active surgical debridement. The picture on the bottom is that first patient. So this now looks a little bit different than that first wound. And that's showing you that there's been some debridement done. And so we're getting a sense of what? When I teach people, I say, I want you to debride until you see blood. That's important because at the interface of the atmosphere where you can see what's going on and the blood supply, that is where tissue is going to be viable. You need blood to heal, whether it's blood from soft tissue sources or whether it's blood from a bone source. And you have to use rongeurs and cut dead bone off until you get bleeding bone. That is important, okay? And it's something that you can't be timid about. Very important in all of this is analgesia, and what I'm a big believer in is local anesthetic. Lidocaine infiltrates and lidocaine splash blocks. They are the most effective for a trauma to the appendicular skeleton by far. Nothing systemic even touches it. Okay. Very often you'll need sedation and sometimes deep sedation. Okay. So we do the kind of conventional things, surgery, some medicine. Now we're layering in things that we've kind of developed, which are the molecular therapies, which I'm going to get to in the next slide. But in addition, behavioral therapies. Because what happens is an animal that has not been using its limb correctly and may have a secondary buoyancy syndrome associated with the presentation, they learn a new muscle memory. They've been floating for weeks and months sometimes. So their new normal is actually a pathological normal. So often, even if everything was fixed, they don't know how to dive. They don't really know how to swim anymore because they've lost kind of that repetitive behavioral trait that they utilize under normal biological behavioral conditions in the ocean. They've lost it. It's almost like if you sat down for 4 months and didn't move, that moment when you stood up, it would be a little shaky, like your legs will have forgotten what to do, your lower back, everything. In your mind, you may know, but your body, it's a different story. Okay, so we deal with that with a couple of therapies that I'm going to introduce to you today. And you may already be practicing versions of this already. Okay. Now, on the integrated side of what we do, the integrated management, that's just a fancy term for just pulling together conventional, and sort of non-conventional, sort of the molecular cell-based therapies, and then traditional integrative therapies like uh, uh, class 4 laser therapy like acupuncture, traditional Chinese medicine, things like that. So we do all of this. So photobiomodulation is that class 4 laser. This works wonderfully well. It works well for accelerating healing. You can do it when your patient is out, say, getting fluid therapy. You do it at the same time. It can be dangerous. It can be dangerous to your patient and to you. So it's not just like a little fun toy. It's a medical device. Um, so that is used all the time in our practice. Um, it also has very uh, well-known pathways. The pathways are very well known where it intervenes in managing pain, certain types of pain. So you have the tissue healing component combined with the pain relief. So it's non-invasive. So it's just wonderful. It's not a cheap device, but it's something that's worth considering in your practice. Now, the activated platelet-rich plasma, which is the top picture in the left there, that schematic, that's what this is. And then stem cell therapy. So let me just kind of give a broad overview. Both of these are products of the animal's own cells and molecules. That's important because you're not introducing something that's foreign, that's a drug that really costs anything. The processing may cost something, and the processing requires some expertise, but the medicine, so to speak, comes from the patient. And so that's it's a very nice holistic story. It's a very wonderful clinical story and outcome, and it's something that crosses cultures too. Like you can convince and persuade people like this is a really good technique because it's just using the animal's own healing properties. You're not doing much to it. So the platelet-rich plasma is the middle part when you spin this down, and spinning it is the perfect way to do this is a special centrifuge that spins at a certain angle at a certain speed, and you get the maximum platelet-rich segment of this of the separated blood product. You don't have to do that. You can use your own centrifuge and you'll get a perfectly good, nice column of the platelet-rich plasma. Okay. The platelet poor plasma is actually very valuable for something else that I utilize, which is not the subject of this lecture, but it's something that's worth knowing is that you can use the platelet poor plasma for pleurodesis if you do endoscopic surgery to repair tears in sea turtle lungs. The platelet poor plasma has all the fibrin, and that's the kind of the super glue of the blood. And then the red blood cells, obviously, you can utilize just measuring that to get your packed cell volume, and you can freeze these too, okay, or chill them and keep them in the refrigerator for like a week, and they still are good as therapeutic devices for your patient or for therapeutic interventions. Acupuncture. So I talked about that a little bit. I'm not going to get into it too much, but there are some very simple acupuncture points that we use. And we use all of this together. Okay. Stem cell therapy is probably the gold standard of all of this, but that requires a lot of skill, it requires a separate surgery, and it requires growing the stem cells, isolating them, and then growing them in a special culture. And it takes some skill to do that, but the outcome is phenomenal. It just fixes everything, just like in human medicine. So we use that more. I use it in Saudi, but in Maldives, it's something that we don't use often. Um, and so the acupuncture. So we use a version of acupuncture that's called aquapuncture. So instead of using dry needles, really using hypodermic needles because their skin is so thick that acupuncture needles usually don't penetrate very well. But the needles, dry needles in conventional acupuncture have to stay in for 20 or 30 minutes. And sometimes you want to get your patient back in its tank. So aquapuncture, you utilize the exact same points, but you use a little bleb of a fluid. And I use vitamin B12, but you can use anything. You can use saline. Even some people use water. And the point, a bleb, I'm talking about like a drop. Uh, the point is to agitate that acupuncture point therapeutically, just like the needle does. Okay, but you do it quickly. It's just a boop, and that's it. You're done. And so we utilize that in these cases as well. Now, the behavioral therapy. The two things we use here that are really the most kind of bang for your buck, your most beneficial, is one is called targeted external weight therapy, and the second is kinetic buoy therapy. So I'll show you images of both of those in a second in a few video clips. So the targeted external weight therapy is just like it is what it sounds like. It's the application of weights to the carapace, most frequently, sometimes to the plastron, in very specific locations to help to gradually allow and aid your patient in relearning how to swim and dive and surface again. So basically relearning how to behave normally as a sea turtle in its natural habitat, which is the water. And so it's not just a question of, just sticking a weight on the sea turtle and say, okay, I'm done. It's very deliberate. So I don't recommend doing this at all unless you're going to spend the time, the resources, it's not expensive, but the time to monitor your patient constantly and have the ability to adjust the movement and the size of that weight on a very frequent basis, like every once a week if needed, and take the time to watch what happens when you do it. Because even a very small weight moved even 1 centimeter or less, depending on the size of your patient, will have enormous changes in its behavior. Okay. So this has to be done responsibly or don't do it at all. The second thing is kinetic buoy therapy, which is utilizing buoys and food items in a movement or a kinetic way. So we attach a food item to a floating buoy that's suspended in a specific location in the water column, and then we use a pole with a hook attached to it, and we effectively create a prey predator response. And we have our patient who gets interested in that food item chase that food item and buoy around and around the tank. And it's not just, okay, swim in circles. We change direction abruptly. We lower that food item into the water column so the patient has to work at getting down into the water column. Okay. So it's an exercise and not just having your patient relearn the ambulatory part of it in its recovery, ambulatory part of its appendicular skeleton, but also for the lungs to recalibrate what it's like to dive. Because if you're at the surface for 6 months or 8 months, your lungs have definitely forgotten what to do. And sea turtles, as you know, have a very exquisite ability to utilize gas in their lungs at just enough volume to get to the water column that they need to get to. And really what it is getting them down 1 meter. If you can get a patient down into 1 meter of water, and any of you who swim or dive know that the work it takes to get into the water, that 1 meter, that's the real work. Once you're in that 1 meter, it doesn't take any effort at all to get down to 10 meters. Same with the patient. You got to get him to work into that 1 meter of water and then keep him there so that his lungs realize and his limbs realize that this is where I'm supposed to be most of the time. And you can kind of fake him out by having him chase this food item, and it's a form of enrichment too, but this food item in a very erratic or in a deliberate way. But the point is that you keep him moving, and it's amazing the combination of the targeted external weight therapy and the kinetic buoy therapy, the results you'll see. Now, that's also in combination with all of this other stuff. Okay. What you see at the top there on the right is actually the administration of PRP. And that's Dr. Mariana. She's been with us for a long, long time, and she used this a lot. She's with the Sea Turtle Rescue Alliance now, but that's how it's done. That's a patient. I remember that patient, and that's exactly what it's done. You infiltrate the PRP directly into the tissue in a ring fashion around the wound, all the way around, just a little bit at a time. So let's say you get 2 cc's of functional PRP from your blood draw. You just need a little bit at the margins of where the tissue is healing, and that will really accelerate the overall healing process. How does it do that? Well, the PRP is enriched with not just platelets, which um, have their own cell signaling properties to recruit healing cytokines, but there are also inherent cytokines within the blood that are already there, and they're also localized within that PRP segment of blood. Okay, so all of the cell signaling that needs to happen um, intracellularly and extracellularly is captured in that fluid, in that medicine that came from your patient. And then finally, probably the most important thing is you've got to be vigilant with this. You can't just do one or two things and say, okay, halas, I'm done. No, just like anything, you got to keep monitoring your patient because you can apply something like weight therapy. You can do something to the limb like a debridement, and you can cause damage to the tissue, or you can cause something behaviorally with the weight applied just in a little bit of the wrong position. And you have to readjust then. Okay. So there's no shame in any of this. I mean, this is part of the process. It's a very dynamic process, but you will be rewarded. The patients will do great. Okay, here's some other images of what we just talked about. Now, the top, I'll just go before the movies. The top here, that's that first patient. Remember the one who was the genesis of all of this? That's what it looks like going into this. So you see, it's not looking so bad anymore. And this is probably after 2 months of work. This is dry needling. This is not acupuncture. And that's exactly how uh, you do it for this type of wound. Okay. So if you have a wound that's open, um, you do a ring around it with a very small gauge hypodermic needle, or you do the equivalent with acupuncture. All right. You don't do acupuncture and PRP therapy on the same day. Okay. You give them a break in between a few days. PRP is done once a week. Okay. It can be done more frequently, but usually you're limited by the amount of blood you have. So you have to be judicious with it. Um, And one thing I would say with acupuncture is that if you have a patient with profound heterophilia, do not utilize acupuncture. There's enough of anecdotal evidence that I've experienced and colleagues of mine that have experienced that something happens in not a positive way when acupuncture is applied during a profound heterophilia. And in traditional Chinese medicine, they tell you this anyway, whether it's human or animal, that you don't use acupuncture if you have an infection in the blood of your patient. Okay. And this, Dr. Mariana, again at the bottom, applying the laser therapy. That's what it looks like. It's very straightforward. And you see here the weights. This is targeted external weight therapy on this patient. Ooh, okay, that's what it looks like. These are weights that are applied in very specific locations for that to get neutral and then in the water column and to get that patient down into the tank in a way that is conducive to the overall healing process. Now I'll start at the top here, which is this is the kinetic buoy feeding. Okay, so this is us with this patient. Oop, let me start back here. So this is the tank. You see that they're walking. That's Michelle walking. And you see that coming across your screen. This guy is chasing and chasing and chasing. This is a male here, big male, and he finally gets it. So you do reward him. All right. So I want to show that again. You do reward him, with the food. But this guy starts like this, and he's down about a meter, and you see his effort is not as vigilant once he's in there. Of course, he's popping back up because he's still a buoyant patient. And like I said, very often you have buoyancy syndrome combined with entanglement trauma. But that's how this works. And that goes around the tank, or you move him down deeper, or you take him shallow. You do sharp turns. So you find places that he needs to work, and then you work him there. You make him become kind of unlazy because some patients, as you know, are, more motivated, and some are a little bit lazy. And the males, especially the adult males, can be very lazy. So once you see and you get to a food item, and that's an adult male, Olive Ridley, by the way, if you get to a food item that they covet, utilize that as currency and utilize that to get to work. Now, this is a buoy feeding that's not kinetic. So at the very beginning of this process, we start with this. Before they can move around under the water, they can't even get under the water. So we start them with just a stationary buoy, okay? And that's what this is here. So let me start that. And so start again. So he's going to come at this, and you see he's trying, and see the weights on him too. He's got the top. No, he can't get it. He can't get it. That's okay. They will make attempts. They will make attempts, and then they will give up. But I don't want you to think that we're cruel here. So he did get his meal. Let's see this again. He finally got to it. See, there we go. So it's this is again an exercise in fine-tuning what you're doing. We actually have our team evaluate this every day. Do we drop that buoy even a centimeter? That makes a difference. When you see that they're getting that food item easily, then drop it. If you see that he's not getting it easily and then he starts to give up and is disinterested quickly, then you need to raise it back up. And they'll have good days and bad days just like we do. So just because one day, oh, he didn't get to the buoy today and he did yesterday, so what? Give him a shot at it. Sometimes I will even instruct my team to look, if he's not getting it or not showing interest, maybe he's not hungry. Okay. So especially the adults, they will go in that cyclical pattern where they just don't want to eat or they don't eat. And so there's no harm in fasting them a day or two to see when they return to food being presented to them, are they going after it with more vigor? That's another kind of diagnostic tool that you can use in your repertoire as clinicians, okay? So there's flexibility in all this, and there's that kind of creative thinking too. But the overall picture needs to be something that you have an end goal in mind. And so all of those pieces come together. So here are some really great examples of patients that have gone through this. Now, this is, let me see, one, two, three, four, five patients here that are in front of you. So you see when these come in, what they look like. Like this is something that 5 years ago I would have, or maybe 7 years ago I would have amputated. I wouldn't have bothered. I mean, the bone is sticking out. This is just awful. I mean, this is like, are you kidding me? But actually, I'm not kidding you. You can save these things. Now, rear limbs are important. Why? Not just for like fine motor movement within the water column. They're not limbs of propulsion. But if it's a female, these are very important, as you know well, that these limbs to be intact. Okay. Here's another patient here, a front limb. Again, limbs of propulsion are very important. The cranial limbs are very important. So this, again, coming in, like they really look really bad. And look at this one down here. So this is just stuff that you would amputate. If you have it around the neck, let me just speak to that really quickly. Now, these have all gone through exactly the protocol I just showed you. Now we have about 25 animals in our database that have gone through this kind of integrated trauma management program with all of these factors that we presented to you today. Now, if you have trauma around the neck, they are usually very well-muscled animals, like you can see here. You need to be careful ventrally because the trachea is right, and the glottis and all the structures and fine structures around the neck are ventral, are very superficial on the ventral surface. So you can have a strangulating or an entanglement ligature wound that can cut through soft tissue and into the trachea and slice into the trachea. It's repairable. That's a repairable defect, but just be aware of that when you're removing ligature material from around the neck. All right. So this is evidence of the type of things that you can save in doing this type of technique. Now, one thing I should point out too, when you see this exposed bone, sometimes you have circumferentially denuded tissue around a long bone, let's say the humerus. Now, you would think that has to be something you should amputate. No, give it a chance, because unlike mammals, sea turtles and other reptiles, sea turtles have a profound blood supply within the marrow of the bone. So the bone could have no tissue around it, but it still has the ability to pass blood from the proximal tissue to the distal tissue on that limb. That's an important thing to remember. The distal limb will not be innervated for proprioception or nociception, mostly nociception. It will not be able to feel anything because the nerves associated with that nerve tract, are gone. but the proximal joint is still intact. The shoulder joint is still intact. And the distal tissue is still viable and intact because you have that blood supply through the bone. And all you need is that joint to be intact, the shoulder joint, and it could utilize that limb, even though it doesn't feel it, it can utilize that limb for ambulation in the water. So it's worth saving, in my opinion. All right. And so we do that. We do that. And that's some of these animals actually had that exact thing. You can see there was not much nerve intact in some of these limbs. Okay. Now, this is that little grain on the day of his release. So this is how he presented. And this is what happened at the end. No, not a perfect picture, but close enough. And he had about 80% range of motion in his distal to his carpus there. Okay. So this does work, and it works in all life stages. You saw a number of subadults, adults certainly in the previous slides, and this is a juvenile that's this guy's maybe 3 years old, 4 years old. So juveniles still have the ability within their platelets to to utilize the healing properties, even though the hematology and biochemistry and all of that of young juveniles especially is very different than an older animal. It still does have platelets and it still does have cell signaling cytokines uh, to advance the healing process. If you, as kind of like the clinical shepherd, because that's kind of like what we are with this, we're shepherding tissue in the right direction to heal itself. So if you're a good shepherd in the right way, so to speak, you can get these kinds of results, and it's worth saving. It's worth saving. Okay. So that concludes my chat with you today. And again, I just want to reiterate one of the reasons we're here is to share this really important part of the year for us, which is this big give. We can stretch in wildlife medicine. I think all of you who are here who are involved with it, you can stretch $1 a long way because you need to. You know, you don't have the luxury of having owners that have money that can spend and all of that on patients. So we're very good at maximizing the value of every kind of dollar or pound or rufiya that we bring in. But this is a big one. This campaign is a big one. So if you can find it within you and you want to give us a little hand, every little bit counts. And as Iyad said at the top of this chat, we're about 60% of the way there, and we're about halfway through, I think, this big give week. And I know you're going to be hit up by a lot of other charities too. God bless all of them. They all have great missions, but I'm a sea turtle guy, so I'm going to advocate for my patients on this World Veterinary Day. All right. So I can open it up for questions if there are any, and we can go from there. If not, then
I think the first question is from Elena. Uh, she's asking about um isoflurane. Is it recommended, not recommended in sea turtles for sedation or anesthesia, or is it true? What do you think about
okay.
it?
Yeah, that's a great question. It's a subject of another lecture, actually. So thank you for the question, Alina. So let me answer this briefly, but with the right amount of information. Um, we do not know very much about pulmonary physiology in sea turtles. We know even less about pulmonary physiology in sea turtles under anesthesia, and even less about cardiopulmonary physiology of sea turtles under anesthesia. So the use of an inhalant, whether it's isoflurane or sevoflurane, which I used to use all of the time because that's all we had, brings you into the area of danger because there's a lot of unknowns you're dealing with. And one of the things I know that happens during gas anesthesia with many species, but it's particularly with sea turtles, is that the brain of a sea turtle does not respond in the same way that other species do. So the quality of anesthesia or the reliability of anesthesia is not there with inhalant anesthesia. That's the first thing. The second thing is we know that inhalant anesthesia can vasodilate on the venous side. It's a venous vasodilator, and less so arterially. I have done central venous pressure measurements in sea turtles under gas anesthesia. Literally, I've had a triple lumen catheter in the vena cava at the level of the heart, measuring central venous pressure. I measured central venous pressure under sedation and then general anesthesia. The central venous pressure of a sea turtle is close to zero under the best of circumstances. It's almost non-existent. That's why our patients don't bleed out when you have serious trauma because their blood pressure is so low. Now, if you have them under gas anesthesia for a good amount of time, you basically are guaranteeing that central venous pressure is zero, and by extension, the peripheral venous pressure is zero. So you're introducing localized and transient periods of end organ ischemia during general anesthesia with inhalant. So all of the things, and I saw secondary evidence of this happening like with patients later. The third and probably one of the most important things from a logistical point of view is that it can take hours and hours and sometimes days to recover them after this. So it's just bad on many levels. Fortunately, now we have injectable anesthesia, which I use exclusively. We do not use gas anesthesia. I do not personally. I don't train it anymore, and I recommend don't using it for the reasons I gave, but they're much more in depth. I just don't have time to go into it now. But the injectable that we can use is dexmedetomidine or medetomidine if that's all you have. And it's a wonderful, safe cardiopulmonary sparing drug that is reversible and reversible reliably and safely. I have lost patients under gas anesthesia. I have never lost one under dexmedetomidine. It's a wonderful drug. We can talk more at length if you want, like if you email me and I can give you dosings and things like that. But I'm fairly confident now to have a hard stop on gas anesthesia. Plus, you need that expensive machine and you have to QC that thing all the time. And it's also a risk to you as the surgeon because that gas escapes. So everything about it is just badness compared to what we have, which is the alternative, which is much preferred for the patient and for you. Okay. I hope that answers your question. Oh, hey, Roya, how are you? This next one. Um, I'm just going to go down the list. Yad, is that
Yeah, we have about 18 questions, but please feel free to sift through them.
okay? I'll try to stick to our time frame. So for your PRP, if you email well, you have my email, but info@oliveridley.org. Um, I'm happy to share that with you and discuss it. If you guys want to do a follow-up talk about some of these things, I'm happy to just share it in another lecture that's unrelated to this. We can organize that too, because I think there may be and it's very easy to do this stuff once you get the system down. Okay. So yeah, please reach out to me directly. Does photobiomodulation therapy risk stimulating bacteria? That's a great question. It's a really great question. In fact, it actually does the opposite from all evidence out there, both on the human side and the animal side, that it actually is antimicrobial too. It may be also related to the fact that because it is recruiting so many molecules within the blood and cells within the blood, including cells of the immune system, that the cells of the immune system are leaving tissue, coming in circulation and entering tissue where you're applying the therapy at a much higher level. So they may be just doing their job, and there just happens to be more of them there, and therefore there's less evidence of bacterial involvement. Okay. All right. For Abdullah, I believe, is it Latif? Um, if the decision must to amputate the limbs, is there any chance possible to use a prosthetic limb, like in humans? Yeah, really great question, and I actually have another lecture on that whole thing. And I don't mean to sound like absolute, but on this I'm absolute, just because not just for sea turtles, but marine animals in general, and especially marine mammals, anything in the ocean, do not apply a prosthetic. It is a torture chamber device for these animals. I can't stress that enough. Now, does that mean technology won't be developed in the future that will negate what I just said? No, it absolutely is. I'd welcome that. It would be wonderful, but we are not there yet. Even with the best engineers, the best kind of where your heart's in the right place, nobody puts a prosthetic on an animal thinking to do something malevolent. They're trying to do the best, but everything about these is just traumatizing and stressful to the patient. Even if it's not obvious to you, to your eyes, it's certainly obvious if you take blood and you test for measures of stress in your patient. Okay, so it's another recommendation that I would say do not do. But in the future, there may be technology that allows us to do it. Okay, Bianca, question about ozone therapy. Yeah, I have experience with that. I didn't include that because we don't use it in the Maldives, but it works great too. It works great too. So if you're comfortable with ozone for the right patient, of course, then yeah, absolutely use it. Yeah, there's nothing wrong with that. These are all really great uh, integrative techniques. So how to attach the weight on the carapace from an anonymous attendee? Another great question. It depends on your patient's size and species, mentation, the type of buoyancy you have, the severity of the buoyancy, and what you have available to you material-wise, and also personnel-wise to be able to do this stuff because it doesn't just get stuck on easily. So what we use in the Maldives is a weight, whether it's a fishing weight up to the size of a dive weight and all the way down to the size of a coin for like a little post-hatchling. And we utilize a gauze between the weight and the carapace itself to provide an interface there. So we minimize tissue trauma with the weight, on the keratin layer. And then we use K tape, so kinesiology tape across that, which sticks down on its own. And then we apply super glue around the borders of that K tape. And we just do it that way. There are ways to utilize more rigorous adhesives for long-term buoyancy cases where the movement of that weight doesn't have to be moved around much. It's just a question of keeping it in place and very gradually maybe increasing the weight, but you can sometimes use a little base um, uh, um, where that weight's attached. A base meaning like a zip tie base that you can use marine putty to apply, because the marine putty you can chisel off without much stress to the animal or damage, and that patient will be okay. I would not use any type of adhesive like the kind that you use to apply a satellite tag. That's way over the top. That's contraindicated for weight therapy. But you can keep it very simple with just super glue and K tape. It works very nicely. Okay, I hope that, again, if I'm not answering it to your satisfaction, just info@oliveridleyproject.org. Okay, Melina, at what point in the hospital would you extract the blood for PRP since they usually come dehydrated? And do you use antibiotic drugs during the process, even if the heterophilia is stable? Okay, some great questions. All right, so the dehydration is something that is not really clinically a problem because that's corrected very easily. What they do usually have is anemia, which is a separate problem altogether. And associated with anemia is a hypoproteinemia or low total protein or low total solids. That can be a little bit challenging because you don't want to be removing whole blood when your patient is anemic. So I usually keep the hematocrit or the packed cell volume at around, if it's say 18 or lower, 15 at the most, but 18, I don't take blood. I just don't use PRP. Until I see a regenerative response in the blood smear, I see immature red blood cells being produced in the blood smear directly, and I see the PCV going up. Once I see the PCV going up, and that can take some time, I still don't worry about the limb. It could always be dealt with later. Like I said, I wait for the PCV to come up and then I take the blood. So remember, you always stabilize your patient first. And actually, why don't we just stick at 20 as a recommendation? If packed cell volume is below 20, just wait until it starts to move up. and then you can start to take blood. Um, the antibiotics, no, I only use antibiotics if there's a confirmed heterophilia by CBC. I never give it empirically. It doesn't matter how bad the wound is. And in fact, most of the wounds, there is no heterophilia at all. So you don't use any systemic antibiotics at all. Remember, all of these drugs have a consequence. If you give an antibiotic just because you think it's a bad wound, without doing a CBC and really getting a sense of is there a heterophilia or not, you're doing your patient harm because you need to give that antibiotic for months in sea turtles. And whether or not that's known in the community here online, you can't give antibiotics for 10 days or 3 weeks or something like that. That will come back and bite you in the rear for sure. You need to give it for at least 2 months. I recommend 3 months. And this is for all antibiotics because that's how their physiology works and their immune system works. So always remember things like that. You got to make sure it's confirmed diagnostically. Yes, I have a heterophilia, and yes, it needs to be treated. Then I give antibiotics, but I don't just give it because there's a really bad wound. In fact, most of those patients you saw with those really bad entanglements, they didn't have antibiotic therapy at all. Okay, something important. Okay, if the bones of the joints are not connected at all, what do you do? You can still attempt to save that limb, provided you have soft tissue that's viable around it. Okay, so if the joint is the joint capsule is open, but this, like that little green, that is like the example I gave, that joint was gone, but the tissue ventrally and the tissue laterally was intact, and there still was a blood supply. And this was an important joint. That's the elbow joint. Um, so that's why it's important to do a good examination and make sure and take your time, okay, and make sure that the tissue is both viable and even better if it has a response to it to nociception, okay, in your neurological exam. So you can still save that limb with a joint destroyed, okay, and the limb will function as a functioning limb, not the way he was born, but it's still functional. Okay, so you could attempt it because you can always, in all of these cases, you can always default back to an amputation. At least you tried. It may have been some time, maybe some resources too, so you have to judge that. But that's something that you can attempt. I certainly would. Yeah. Daniela, if the bones are fractured, yeah, absolutely, even better. Yeah, you can have a humerus fractured and it will be fine. Now, if it's an open wound and the bones are fractured, the same thing applies. You've got to make sure that you have a chunk of tissue that's viable. If the bones are fractured and it's a compound fracture, that blood supply that's within the bone is gone. That's not going to come back. Don't ever try to fix bones either with plates and screws. That doesn't work with these species either. So if you have soft tissue, if you have a chunk of muscle that's surrounding and that's contiguous and that connects the distal to the proximal segments of your limb, then you can still try to save it. We have had, and I didn't have it in this lecture, we have all kinds of funky, like I don't know if you can see me, but like limbs that are folded in half and they stabilize and heal that way. And guess what? That animal can use that limb as a functional flipper. It may not be as hydrodynamic as its native flipper, but it still provides some propulsion, and he's just fine. It's analogous to like a dog that gets his leg amputated in the opposite analogy. He has no idea the leg is gone. He hops around just fine with 3 legs. It's the same thing with our patients. Just because it doesn't look like it's going to function, give it a chance. It may. Okay, so I definitely try that. Yeah. Hi, Giovanna. How are you? Thanks. I have secondary infections. Yeah, I touched on this a little bit. So I'm a very, very big stickler on blood work. Like we are religious about it almost. You need to have a confirmed heterophilia or don't use antibiotics because you're not only doing damage to your patient in the sense that you have to keep them on a therapy that's unnecessary. You're destroying their gut microbiome for one, and it takes a long time to restore that. Okay, so their absorptive capacity as just an organism is diminished because you're giving antibiotics unnecessarily. So give it. Secondary infections, again, I go through kind of a flow of maybe 2, 3, or 4 antibiotics that we know work in these species. We know they're safe, and we know they hit a good amount, nearly all of the aerobic and anaerobic species of microbes that give us trouble. All right. So I don't give antibiotics on arrival by any means. I first do CBC. If it's warranted, I do, but it's not often. It's not often. Yeah. Probably like I've got maybe in both in Saudi and in Maldives, I have about 30 patients combined, and I think maybe 25% are on antibiotics right now, and they have some really bad problems. So it's always determined by CBC. The weight therapy, Ignacio, I'd love to. It's a really important thing because it can be deployed immediately in your practice. You don't need anything fancy, but it's got to be done the right way. Um, Maybe we can do another lecture on that. I feel like I'm shortchanging you guys by not talking more about that, but we're kind of limited by time. I'm even going over here too much too. Um, I'll tell you what, um, why don't we maybe go for 5 more minutes, and then a lot of these things we can I'll follow up with, and then maybe we can do like a joint lecture together again. Hey, Vivian, wait, hang on. Anonymous, after applying PRP, do they stay dry for a while before submerging? No, right away you can put them back in the water. Yeah, right away. I didn't get into topical of this. There is a topical protocol too. I do not use any commercially available antimicrobial creams. Don't use any of that stuff. It doesn't work, and it can cause problems. And you're also introducing something into the tank water that's being broadcast all over that animal now as it diffuses and other things. And there's a chance you're contributing to microbial resistance, antimicrobial resistance. So I use the basics. If you have tricide, I use that, which is just a potentiator. It's not really a drug. But if you don't have that, I use honey. It doesn't have to be Manuka. It just can be any honey that's not pasteurized, just raw honey. But before the honey, sorry, I use betadine, only that, which is povidone and iodine. 10 minutes of that, and then apply the honey. The honey will stay on in the water even for a few minutes or longer, and that's it I use for topical, which is the next question there. Yeah. Yeah, definitely just that. Tricide, betadine, and honey. It's the best. Betadine is the best for everything, I promise you. Okay. It's cheap and it's not controlled or any of that stuff, and it's not dangerous to the eyes or anything. And so use it without really any. And also remember, betadine also kills healthy tissue too. All right. So you're killing the bad stuff, but you're also the new cells that just formed on that outside layer. Those are going with this. All right. Just so you know. Um, okay, Rupan, how are you? The one patient on the slide. Oh, okay. So yeah, that one was just to show you that acupuncture was part of the overall treatment plan that involved this integrative approach. So I utilized that while he's out getting fluids or getting, I forget what other therapy he was getting. I would use aquapuncture. Now that patient was the very first patient I ever did. This is back in South Florida. This is years and years ago. So I did dry needling, but I thought, like I said, there's got to be a better way. I don't want to keep him out of the water for half an hour with these needles stuck in him, and he doesn't like it. So I just use the acupuncture in the same points, just a ring around it. Okay. How about one more anonymous, and then we'll call it a night. Are there any recommended bandages to the humerus? Okay, so this is a really good question. I didn't even touch on this at all. I'm a firm believer, do not bandage anything ever, or very rarely, very rarely. Sometimes on the head you have to. Keep that wound open, okay? These species are designed to heal in the water. Don't dry dock them thinking that if I treat them out like that and pack it and wrap it, that it's going to heal like a dog or a human. Their tissue works in the opposite way. They must be submerged in water. That doesn't mean you neglect it, but keep that wound open and just be vigilant about its care. but don't wrap it up, don't bandage it, don't cover it, don't splint it, none of those things. Let that thing heal on its own with this integrative approach, which is all cell and molecular and medical and some surgical based, but there's not any structure except for the weight therapy. There's not any structure applied to the trauma itself. Okay. That's really important. Just like you don't pin or screw or plate these things, don't apply any bandages. You're going to run into trouble. All right. I've learned that the hard way myself. Okay. All right. It's where I am at 6:15, so let's cut it off there. And I think I really thank you guys all for your great questions and chiming in on the weekend. And we'll advertise again maybe for a second lecture. If you guys just really quick are not part of the Sea Turtle Rescue Alliance, please join. It's free. It's seaturtlerescuealliance.org. That's where all the sea turtle surgeons get and veterinarians get together too. But have a wonderful World Veterinary Day, and thanks again for tuning in. Okay, I'll hand it off to Iyad now.
Thank you so much, Dr. Max. I think you've, in a very short time frame, impressively managed to answer so many questions, but we still have so many more to go. And we thank you so much, everybody, for your engagement, your interesting questions, and your enthusiasm as well. It's been great. And we see a potential for future webinars as well, and we hope that you join in. And if you still have any follow-up inquiries, please feel free to reach out to us at info@oliveridleyproject.org. We will make sure that you get as much as information we can possibly provide for you, depending on how the question works out. And once the webinar ends, I would just like to say you'll receive a short post-webinar survey where you share your experience regarding this webinar with us and let us know if you'd like for us to definitely host more sessions like this. If you'd like to join in, if you'd like to bring in more of your veterinary fellows out in the field, your colleagues. Thank you once again, and we hope you continue to engage and support sea turtle conservation. Um, thank you so much for joining in, and that's it for tonight. Thank you.
Good night.
Good night, everybody.